Okay, I'm going to go ahead and get us started here. We're going to take a look at fluid and electrolytes today. And reminder that Wednesday is a holiday, along with Thursday and Friday. The school is closed, so there is no lecture on Wednesday. So this will be the only lecture we have this week for AP2. And of course, we're done with lab. There is no lab either. So anyway, let's see. Any questions on anything before I get started? Today we're taking a look at fluid and electrolytes. Okay, and I'm going to go ahead and get in here. And open up. Okay, fluids, electrolytes, and acid-base balances. Now, this is something that sounds tedious through here, but you'll find as you go on in your healthcare career, particularly if you're going into nursing, that this is going to be something that becomes extraordinarily important to you. There is no faster way to kill your patient than by getting their fluid and electrolyte levels out of balance. Because once they're out of balance, it's very hard to get them back. A person who goes into kidney failure, which causes this imbalance, will generally be dead in about 48 hours. So fluid levels are very, very important to understand the components of various fluids in our bodies and why our body does things it will do. So, and we are mostly water. We've been emphasizing that ever since AP1. We're mostly water. It varies depending on age. You know, infants are more water than like 80% water, and we're probably 70% water now, and elderly individuals are probably in the 40% range. That's why their skin wrinkles. That's why elderly people have wrinkled skin, because their water levels are low. Now, in our bodies, we have water in two areas. We have it in the intracellular fluid within our cells, and we have it in the extracellular fluid, which is the plasma of our blood, and the interstitial fluid that is the plasma that leaks out around the cells. That plasma leaks out, it becomes interstitial fluid, is collected by the lymphatic vessels, and then drained back into our plasma. Now, the other fluids that we have to take into account, we have cerebrospinal fluid. That's only about 5 ounces of fluid, though, 150 mils, if that much. We have fluid in the eyeballs. We have fluid in our joints, the synovial fluid in our joints. We have the fluid that lines our serous membranes, and we have all the fluid that comes out that's released in our gut. But altogether, we have just two key areas: inside the cell, outside the cell. Outside the cell is plasma and interstitial fluid. That's the bulk of the extracellular fluid is mostly plasma and the water around our cells. So this summarizes, if you like visual, this shows you the bulk of our water. 25 liters or so is in our cells. Our total water volume is about 40 liters. So an individual, as adults, we're about 60%, 60 to 70% water. So about 40 liters of water, 25 liters is found inside the cells. The remaining 15 liters is divided up between the plasma and the interstitial fluid, with only 3 liters found in plasma, only 3 liters in plasma. And so if we drain water, if we lose water from the plasma, then we lose water in our interstitial fluid. And if we lose water in our interstitial fluid, our cells will give up water to try and reach equilibrium. So an individual that becomes dehydrated, the whole basis of being dehydrated means starts with losing fluid from plasma. Person has too much alcohol to drink. Alcohol makes you pee. It suppresses the release of antidiuretic hormone. Antidiuretic hormone controls the need to pee. Well, you suppress that, and we all know people that have had too much to drink, and we've all seen the consequences there. They have to keep peeing and peeing and peeing, and then they become dehydrated. Well, where's that water coming from that they were peeing out? Ultimately, it's coming from their plasma. Plasma becomes interstitial fluid, gets returned back to plasma. Plasma goes through the kidneys. 20% of the plasma is filtered every minute. And if we're not going to recover that plasma, we're going to pee it out as filtrate, as urine. And so when we become dehydrated, we're losing water from our plasma. Our cells will respond. The great bulk of water in our bodies is found in our cells. So our cells will give up water to the interstitial fluid, which will go back to the plasma to try and make up for this water loss. And so we see the cells shrink. And the only way the cell knows to give up water is because the salt concentration out in the plasma in the interstitial fluid rises. If we don't lose salt, we only lose water. Now, what about something called hypotonic hydration? With hypotonic hydration, it's just the opposite. We are drinking too much water. We take in more water than necessary. We dilute the plasma. We dilute the interstitial fluid. The salt concentration in our plasma becomes less because there's more water. Not because we lost salt, but because now we have more water. Well, at the cell membrane, the interstitial fluid is less salty than what's inside the cell, and water goes into the cell, and the cell ends up swelling. Cells don't like to shrink, they don't like to swell. Now, within the plasma and the interstitial fluid and the intracellular fluid, we are mostly water, but we have solutes in place there. We have solutes that are broken out as either an electrolyte or a non-electrolyte. The electrolytes hold charges, like sodium is positive, chlorine is negative, hydrogen is positive, calcium is positive, potassium is positive. OH groups are negative. So these are the salts, the acids, and the bases that will have a charge. Some proteins are thrown in there too, like hydrochloric acid, positive hydrogen, negative chlorine. Sodium chloride, positive sodium, negative chlorine. So we have these are what we call the electrolytes because they will hold a positive or a negative charge. And the non-electrolytes are the large molecules like glucose and fats, creatine, urea, things like this. These large molecules don't have a charge, which means they also don't go into solution as easily as the electrolytes do. Electrolytes have a greater osmotic power. They will move water across the membrane better than the presence of glucose, for example. Glucose doesn't have as much osmotic power as sodium. So electrolytes are going to dissociate into ions in water. We've seen that happen with sodium and potassium, sodium chloride. Sodium chloride, salt separates in water with the positive sodiums and negative chlorines, and they generate an electrical current. We have sodiums on the outside of a cell, and we have potassiums on the inside of a cell. We generate a resting potential, a charge on the cell membrane based on the charge of the ions inside and outside the cell. We've seen examples of this. Now, why are electrolytes have greater osmotic power? Because when they go into solution, they dissociate into two particles: sodium chloride, a sodium ion, and a potassium ion, a chlorine ion, magnesium chloride, a magnesium ion, and two chlorine ions. That gives us three particles. Now, solution, the osmotic pressure in a solution doesn't care what they are. All it pays attention to are the number of particles. The solute concentration is based on particles, not what they are. Glucose doesn't separate into anything except glucose. Glucose gives you one solute particle in solution. Every glucose molecule is one solute particle, but sodium chloride gives you two different particles. The more particles you have, the greater osmotic pressure you have to move water one way or another. Okay. That's okay. I understand. So now let's move on here and talk about how do we measure electrolytes in solution. Well, the correct term is milliequivalents per liter. It's a measure of the number of electrical charges that we see in a liter of solution. So, and if you really want to get technical on it, a milliequivalent per liter is the concentration of the ion in milligrams per liter over the atomic weight of the ion multiplied by the number of electrical charges on one ion. Okay, so for our convenience, we convert 1 milliequivalent into a term which makes more sense for us. One which we use more universally is 1 milliosmol. 1 milliequivalent equals 1 milliosmol. So what does that mean? Well, we mentioned this a little bit in the urinary system. The average osmotic concentration of the human body should stay around 300 milliosmoles. So we don't have to pay attention to the milliequivalents too much here, but 300 milliosmoles is the osmotic concentration we want to see in our bodies. If we drop below 300 milliosmoles, we get thirsty. If we go above 300 milliosmoles, we have to pee. So now, sodium is so important to our bodies. Sodium is the #1 ion that impacts our body. No other ion affects the osmotic pressure than sodium does. It is the #1 cation in all of the extracellular fluid, in the plasma, in the interstitial fluid, in the lymph, in the cerebrospinal fluid, everywhere. It is the primary cation, positively charged ion, everywhere outside the cells. Chlorine is the major anion, and that's as far as chlorine gets any respect. Chlorine is literally just watching. Within the cells, potassium is the #1 cation. So outside the cells, it's sodium. Inside the cells, it's potassium. And potassium and sodium are equally balanced in here, inside the cells and outside the cells. But the dominant electrolyte, the dominant ion, is always going to be sodium. So, and we see here where we find these, the highest concentrations. Here's sodium. Sodium is highest in plasma and in interstitial fluid, and very low inside the cells. Over here, we see sodium and potassium very low inside the cells, and we see potassium very high. Chlorine is high outside the cells. So, for example, but it doesn't do anything for us. We don't depend on it for anything. I mean, it does something, we don't depend on it. So now, movement of fluid between the plasma / interstitial fluid and the intracellular fluid. Water moves back and forth all the time, but it doesn't change the concentrations inside the cell or outside the cell. We see water movement back and forth through the octafluorines all the time, but the osmotic concentration outside the cell and inside the cell stay constant. If our patient is in homeostasis, meaning that they're running at 300 milliosmoles osmotic concentration, you're not going to see a shift of water from inside the cell to the outside, or the outside of the cell to the inside. Water movement will be a net gain of 0. It'll go back and forth all the time. Plasma, this is an important one, I even highlighted here. Plasma is the link between both the interstitial fluid and it's the link between the extracellular fluid and the intracellular fluid. Plasma is mostly salt water. Plasma moves into the interstitial spaces, it leaks out of the capillaries and the vessels, and it moves into the cell as water moves out. So plasma becomes a link between extracellular and intracellular. Water is moving all the time, and our link between all the compartments is going to be the plasma. Gases move one way. Oxygen always goes into a cell. CO2 always comes out. It doesn't go the other way. Glucose always goes in. Wastes always come out. So everything else is going into a cell or coming out of a cell in one direction only. But water goes back and forth. And that is the link. If the solute concentration changes at all, we will quickly adjust with water from inside the cell or outside the cell to maintain our 300 milliosmol concentration. 300 milliosmoles is the magic number. We want to stay at 300 milliosmoles for our osmotic concentration. If we get too much water, then the cells will suck up that extra water or we'll pee it out. If we have too little water, we will retain water in the kidneys and the cells will give up water to try and reach equilibrium. Because remember, we don't lose sodium. We don't lose sodium, we don't lose potassium. Those levels are the amount of sodium and potassium in our cells is constant, but the percentage can change. If we increase the water level, the sodium gets more dilute. For example, think back to that magic beaker I've talked about before. You have a beaker with a liter of water in it and 100 grams of sodium chloride. So now you have a 10% salt solution, 100 grams. If we let the water in the beaker evaporate from a liter down to a half a liter, we haven't lost any salt. We still have 100 grams of salt in the beaker, but now it's only 500 mils of water, not a liter. We've lost half the water. We don't lose the salt. The concentration of the salt in the beaker now is no longer 10%. It's 20% because half the water's gone. And if we evaporated all the water, the concentration of the salt would be 100%. So we didn't change anything. Now, if we take our beaker with 100 grams of salt and add an extra liter of water to it, now we have 100 grams in 2 liters. Now the concentration isn't 10%, it's 5%. We haven't changed, we still have 100 grams of salt there. We haven't changed the amount of salt. but its percentage changes as the water levels go up or down. So this how this applies to us is what happens to the salt concentrations in our plasma and in our cells if our water levels change. So how much water do we take in on a daily basis? Well, about 2.5 liters. We get it from drinking. We get it from food. 30% of our food, 30% of our water comes from food. We also generate about 10% through cellular respiration. But 60% of the water that we need comes in through drinking water, drinking coffee, drinking Cokes, drinking tea, whatever. So that's 2.5 liters. 2.5 liters in, and we lose about 2.5 liters. 2.5 liters out. 60% of that loss comes in the form of urine. So the amount of water that we take in is usually balanced, that we take in directly as a liquid is usually balanced by what we pee away. It's about 1.5 liters. So 1.5 liters of water comes in and 1.5 liters of urine goes out. We lose 4% of our water in feces. Feces, believe it or not, are only about 30% solids, which is really unpleasant to think about. That somebody had to evaluate that, So we lose water through insensible losses, through our lungs, for example, through the breakdown, the breakdown of water in different processes in the body, and from sweating. So, so we lose it that way. So we said the insensible causes. If our osmotic concentration rises, we get thirsty. If we lose water, we get thirsty. Who hasn't gotten thirsty? Thirsty, we drink something to quench our thirst. And the trigger for being thirsty is enough of a water loss to trigger an increase in the salt concentration. Because remember, we don't lose the salt. We get thirsty when our plasma and our interstitial fluid gets a little saltier than we like. So, and there's our comparison right there of urine and water intake. We take in directly about 1.5 liters through coffee, tea, Cokes, water, whatever, and we pee out about 1.5 liters. The rest of it is input and output from metabolism and from food, and over here, insensible losses through the skin, through the lungs, sweat, and feces. So how do we control our water intake? How much is enough? Now we know that we're drinking we have to have 2.5 liters of water a day. You don't go, well, no, we don't have to take a 2-liter bottle of water and a 0.5 liter bottle of water and chug all that down at once. That's not what our body is designed for. The old wives' tale said you have to have 8 glasses of water a day. Well, there is a basis of fact in that we need about 1.5 liters. But who determines what size of a glass it is? So we just, that's an old axiom, an old wives' tale about drinking lots of water. Well, the more water you drink, the more you're going to have to pee out anyway. So what happens to make us thirsty? How does our body regulate water? Because this is something we just let to chance. We try to keep our osmotic concentration in our plasma at 300 milliosmoles. If our thirst center in the hypothalamus will get stimulated if our plasma volume drops, if we lose water, because we're going to get saltier. If we lose water, our osmotic concentration goes up. And it doesn't have to go up very much, 1 or 2%. We also see so if our plasma concentration, our osmotic concentration goes above 300 milliosmoles, if our fluid volume drops, if we see our pressure rise or drop, if our blood pressure drops, we want to retain water. If our blood pressure goes up, we want to get rid of water. But here we're looking at thirst. So if our pressure drops, we're probably thirsty. Angiotensin 2 is a vasoconstrictor, and it will tell aldosterone to retain sodium, which will make us want to retain water. Because if we retain sodium, what happens to our osmotic concentration? It goes up. The key here is the osmotic concentration. If we go above 300, we're thirsty. It doesn't matter if we've lost fluid volume, which will make us thirsty, because we don't lose salt when we lose water. It doesn't matter if our plasma, if our salt levels go up, maybe we had a lot of salty food. It doesn't matter if it's if our blood pressure drops, if angiotensin 2 triggers aldosterone to retain sodium, because then we have to retain water. Any of these are going to be the triggers. Now, if we lose water, we're going to get thirsty. We are going to trigger our thirst center if we lose water. If we lose water, we trigger our thirst center. We also trigger the thirst center if we've taken in extra salt, because where does everything that we eat go to? It goes into our plasma. If you eat a bunch of salty food, you're eating chips and salsa, a lot of it, you're going to get thirsty, as the salt's going to go into your plasma. It's going to alter your osmotic concentration by 1 or 2%, and it's going to activate your thirst center in your hypothalamus that says you need some water. And so you will release antidiuretic hormone to retain water at the collecting duct. You will also activate the thirst center, and you'll want to get a drink of water simply by seeing a rise in your osmotic concentration. Our salt level goes up. Yeah. Whether you have had a patient that's had 4 or 5 alcoholic beverages in a short period of time and now they're peeing frequently, or whether they've eaten a lot of salty food recently and they are they're thirsty now because they ate a lot of salty stuff. Salt, either you're losing water and your salt concentration goes up because the salt's left behind, or you add more salt. One or the other, you're going to be thirsty. So your patient you'll drink a glass of water. You'll have a beverage to try and quench your thirst. When you go to a restaurant that serves chips and salsa, one of the reasons why the chips are served is to make you thirsty and buy beverages. That's it's not just altruism. It is part of you expect, a restaurant that serves chips and salsa, you expect the chips to be there and they're going to be salty, and you expect that, so it's not like you're surprised, oh my goodness, I have to go buy a drink because of those salty chips. Well, no, not really. So anyway, if we increase our water intake, we don't get thirsty. Remember, our osmotic concentration is 300 milliosmoles. If we add more water to that, the osmotic concentration drops. We haven't gotten rid of any salt. We just dilute it a little bit. And that our thirst is quenched. We're not thirsty. We are inhibited from, our thirst center is inhibited. ADH gets inhibited. The more water we take in, the more we inhibit ADH, and so we pee more frequently. You can get a similar result to drinking alcohol by drinking lots of water, and you'll have to pee it out. So, because in both cases, with alcohol inhibiting the release of ADH, excessive water intake inhibits ADH. Both cases, you're going to be peeing frequently. we don't lose our solutes. The sodium doesn't leave. We don't lose our sodium. Water can go out, water can come in. We can take in more salt, but we don't lose the sodium. You know, if we dilute our sodium, we're not thirsty anymore, but we're going to end up peeing that extra water away. If we lose water, our sodium level goes up. Now we're thirsty. So now we trick the hypothalamus when we're thirsty. If we're thirsty, as soon as we start drinking something, we're no longer thirsty. Now, it takes a half an hour for the water that we take in, or the beverage that we take in, to get into the plasma and alter the dilute the osmotic concentration from 310 back to 300. It takes a half an hour for that to happen, but we're not thirsty instantly. See, because what we do is when we drink a beverage, we are going to moisten the inside of our throat and our mouth, and that feels good. We're going to stretch we're going to activate the stretch receptors in our mouth and our esophagus and our stomach that tells us we've just taken in a liquid. And so now we will fool the hypothalamus and say, oh, we're not thirsty anymore, even though we haven't reestablished the salt concentration like it should be at 300. We're not, that's a half an hour away, and yet we think that we are not thirsty. Good question. When you drink a soda instead of water, you become thirsty again. Yes, the soda often contains sodium. It also contains high fructose corn syrup, and between the sodium and the caffeine in there and the sweeteners, the sodium in it, first of all, the sodium tells us to sodium inhibits the retention. Sodium causes us to attract more water in, but more water causes us to pee, and so we get thirsty again. High levels of sodium, high levels of the sweetener in there, and artificial and diet drinks are even worse because of all the solute particles. It all has to do with the solute particles in the beverage. The more solute particles you have in there, the more water the more you're going to end up raising the osmotic concentration. The whole idea of drinking something is to lower the osmotic concentration. You get thirsty when your number goes from 300 to 310. We drink something to bring it back to 300. In case of drinking a Coke, we lower it, we bring it back to 300 temporarily, but the sugar concentration and the sodium in there and the caffeine is going to cause us to become dehydrated again. So it's only a short-term fix. Even though on a really hot day, a Coke is really good, tastes very good, but it's the initial drink is great, but it just doesn't it doesn't contribute to get overwhelming your thirst. So okay, good question. Okay, now let's so that deals with thirst. Thirst is all about maintaining that osmotic concentration of around 300 milliosmoles. Patients that are thirsty they may be losing water somewhere. The patient says that they are always thirsty. Why are they losing water? Is that an indicator of diabetes? Is it diabetes insipidus? Is it diabetes mellitus? They're always losing water. Because if they're always thirsty, water's got to be going somewhere. Now, water output, the insensible water losses through our skin, through our lungs, through our feces, through perspiration, and then the what we call the sensible water losses. So what we pee away, about 1.5 liters. There is a magic number here. We have to, and that magic number is 500. 500 milliliters is what we have to see the urine output of your patient on a daily basis, or you're not going to be getting the waste out properly. A patient going through kidney failure is producing less and less urine output. And if the urine output is 500 mils or less, then they're not clearing all the waste, removing them they should, and they're going to be reabsorbed. And the waste products, the toxins, accumulate, and generally when the kidneys fail, your patient's going to die in about 2 days. So, yeah. ADH, back to ADH again. ADH acts on the collecting duct. We talked about ADH ever since the beginning of the semester with endocrine, but ADH works on the collecting duct. It's our last opportunity to recover water from the filtrate, because we really don't count it as urine until it's in the collecting duct and the ADH has finished its job. And so what will happen is, if we release large quantities of ADH from the posterior pituitary, we will retain lots of water. If we inhibit its release, we will only retain small amounts of water and will produce a very dilute urine. If we inhibit the ADH, if we drink lots of water or drink lots of alcohol, we will pee frequently. The urine will be pale, transparent. It will be not removing significant amounts of waste product here because the ADH is just letting everything pass through. So the ADH is triggered by the osmotic concentration. The hypothalamus, remember the hypothalamus controls the release of ADH from the posterior pituitary. The hypothalamus is going to detect the osmotic concentration. If the osmotic concentration rises, if we go above 300, then we will release ADH to inhibit water loss. Because remember, ADH controls water loss. If our osmotic concentration goes up, we don't want to lose water. On the other hand, if our osmotic concentration drops below 300, that means that we're being, if we drop below 300, it's because we're being diluted. If we go below 300 to 280, 270, it means that we've added more water and we've diluted the percentage. Remember, like adding water to salt. So if we get too dilute, then we shut down the ADH so we can pee away that extra water. Okay. Yeah, that 1 beer a day to promote urine output, that makes sense because 1 ounce of alcohol is going to have a very slight inhibitory effect on the antidiuretic hormone. And so if we want to see the patient peeing a little more frequently, what better way to do that? Plus there's 12 more ounces of water that are probably going to pass right through. And so that, you restrict the release of ADH just a little bit. And so you pee a little more frequently. And that, helps to increase fluid output. So, and that's one way. And that's also to get your patient to drink that fluid, because you say, okay, I want you to drink two bottles of water today. Well, first of all, bottles of water come in all different sizes, and the second thing is, then it becomes sort of a onerous, sort of a task you have to do. But say, hey, go home and drink a beer. There's a lot less, pressure on someone to say to have to do that by saying, oh, sure, I'll drink a beer, and I think that it also has a psychological advantage there on your patient, because many people are more willing to drink a beer than to I got to drink a bottle of water, an extra bottle of water. So, good question. Does drinking extra water really help with weight loss? Yes and no, because the extra water goes in, it will fill the stomach, at least temporarily. It will stretch the stomach and create a sensation of fullness. And that will impact on the desire to eat. You know, it will satisfy the stomach, you know, because there is, you know, because the stomach doesn't know what we're eating. It just knows that it's full or it's not full. And we have hunger pangs. And we are all well nourished. We all have many reserves in our bodies that we can draw on. So there, to some extent, you know, drinking a bottle of water before you eat a meal fills up your stomach, makes it easier to eat less in that sense. But again, it's a temporary thing because you're going to end up peeing it back out again too. So, you know, it does aid people in not eating as much, you know, and I think that's part of the whole process there. So yeah, that's another good question. Okay. Now, so ADH, primarily controlled by the hypothalamus, based on osmotic concentrations. People that have severe water loss from burns, for example, or vomiting or diarrhea, will be releasing lots of ADH to try and retain that water. You know, because a person who has been vomiting for several days or has severe diarrhea, infants, you know, go through bouts of this too. They don't have a lot of volume to lose. But this water loss, we can control that. Well, the ADH is trying to protect us from that. But when we have severe, you know, abnormal situations like burns or trauma, blood loss, you know, some sort of pathogenic occurrence, you know, our bodies will try by releasing ADH to retain as much water as we can. Of course, the problem is sometimes the pathogen or the trauma can exert a greater influence. Now, dehydration, something we see more frequently than I think we recognize. We lose water faster than we can take it in. Now, obviously, your patient that has internal bleeding is going to have water loss. Severe burns, you know, water oozes from the tissue, vomiting, diarrhea, diuretic abuse. People take diuretics as a weight loss tool, believe it or not. You know, most of these over-the-counter diuretics are caffeine based, and so an individual who wants to lose 30 pounds starts taking these, and he or she pees away volumes of water. Well, yeah, it's a transitory thing because you're going to start replacing that water anyway. It's not a permanent, it's not a fix, it's not even a temporary fix. But there are lots of people that will do things like that for a short term. Now, the signs of dehydration: the skin is dry, it tense. If you pull up on it, it leaves a ridge. You see the illustration there. You see like a ridge there, a bump that's going on. And this is not good, because if you're dehydrated, the water that you're losing in dehydration is coming from the plasma and the interstitial fluid. And our cells will respond by sending water out into the interstitial fluid and ultimately into the plasma. The cells will give up their water content, and the cells will start to shrink, and cells don't like to shrink. So when dehydration occurs, it's affecting not just the plasma, not just the interstitial fluid, but also the cells themselves. And like in the brain, we don't like to see a water loss out of those cells. So this is dehydration. If we're losing water in the interstitial area, if we're losing water from plasma or from interstitial fluid or both, then the cells are going to send water out. The cells will shrink. They will give up water. They will detect, because if you lose water out here in the plasma, your salt concentration is going to go up, or in the interstitial fluid, your salt concentration is going to go up. Your interstitial fluid will be saltier. It will be saltier than the inside of the cells, and water will go from the cell to the interstitial fluid, and the cell's going to shrink. That's dehydration. So excessive water loss from the extracellular fluid, the osmotic pressure rises because there's now more salt out here than there was before, simply because there's less water, and the cell then sends water out, and the cells shrink. The cells don't like to shrink. Now, hypotonic hydration is just the opposite. If we are retaining water, if we take in a great deal of water, we overhydrate. We dilute the extracellular fluid. So instead of 300 milliosmoles, we're running like at 280 or 270 or 260. We have overhydrated our cells. This produces a situation known as hyponatremia, meaning our salt concentration is now lower. We don't like that. And that causes, we are now more dilute than what's inside the cell, and water leaves the interstitial fluid and goes into the cell, and the cells will swell up and they can burst. You put a red blood cell into distilled water, the red blood cell explodes because there's much more water outside the cell than there is inside the cell, and water goes from high water to low water. And so if you overhydrate the plasma and overhydrate the interstitial fluid, the cells are going to end up sucking up that water because there's more water outside the cell. It will go in, the cell can swell up and could rupture. And that's never good, particularly in the nervous system. So this is hypotonic hydration, or water intoxication. Too much water comes in. Your patient drinks excessive amounts of water. If some is good, more has got to be better. You often see this at the end of a marathon, for example. A runner completes the marathon and very quickly chugs down 5 or 6 bottles of water and dilutes their plasma, dilutes their interstitial fluid, and now their cells are starting to swell up because all that water is going into the cells. They've been perspiring heavily for 2.5 hours, and now they chug all this water. Well, that water goes straight to the plasma, and then it goes straight to the interstitial fluid, and now it's going to go into the cells and can cause the cells to swell up, and that's never a good idea. So, because this can be fatal. Hypotonic hydration can cause neurological damage, can shut down the autonomic nervous system, can kill your patient very quickly by overhydrating. Fluid accumulation is something else we see in our bodies. We have edema, that is swelling. Now, edema occurs usually when we are retaining water for some reason. Now, it may be that we're having an allergic reaction to a bee sting. The patient's stung by a bee, and they release histamine. Histamine is a vasodilator, and histamine also causes plasma to leak out. Not only do blood vessels vasodilate, but the clefts, the openings, become larger, and more plasma leaks out to become interstitial fluid. And it goes into the spaces around the cells, and we get swelling. And that edema is an indicator. It's a symptom of something going on. If the stroke volumes are not the same, for example, If 50 mils are going out of the right ventricle and 50 mils are going out of the left ventricle, that's great. But if the right ventricle is pumping out 50 mils, but the left ventricle is only pumping out 30 mils, what happened to the other 20 mils of blood it was receiving? Well, that fluid backs up in the lungs. We end up with edema. We have pulmonary edema. So we don't like to see that. We don't want to see fluid accumulate in the tissues. You know, congestive heart failure can cause systemic edema in the tissues or in pulmonary edema in the lungs. Also, you know, we see the edema can be so severe that you can make a dimple or a fingerprint. You can leave a mark. This is the quick test. You press on the swollen tissue and on what looks like swollen, and if you can leave a dimple or even the mark of your finger there, then there's a lot of fluid in there. You should not be able to leave a dimple in your patient's arm or leg. It should you press against your skin and it goes away immediately, but a dimple lasts. So that's the indicator that we may have something going on here now. The other problem we have is water loss. You know, we talk about water gain and hypotonic hydration. And in addition to dehydration and hypotonic hydration, we have water loss caused by either insipidus, diabetes insipidus, or diabetes mellitus. Insipidus affects antidiuretic hormone. Insipidus generally blocks something is blocking the release of ADH, preventing the release of ADH. So your patient with diabetes insipidus has two of the signs of diabetes mellitus. They're thirsty all the time and they're peeing all the time. Why are they peeing all the time? Because they can't regulate their water levels. Their ADH levels are not sufficient to retain their water level, to fix their water level. So they're always peeing, and that makes them always thirsty. Because the more you pee, the lower the osmotic concentration. The more you pee, the higher the osmotic concentration gets, and the thirstier you are. So the more thirstier you are, the more you drink. The more you drink, well, now we got to pee it out. And so that's what happens in diabetes insipidus. No antidiuretic hormone to act on the kidney collecting ducts to recover water. Now in mellitus, it's a little different. This is why people with diabetes mellitus, type 1 or type 2 diabetes, have to pee. Here is our filtrate right here. This is what's coming in. We have high levels of glucose in our, we have glucose in our blood because we don't have insulin. Either we're not making enough insulin in diabetes mellitus, that's type 1, or type 2, what's being made isn't recognized. In either case, glucose isn't getting into the cells. So glucose tends to stay in the plasma. And when the plasma runs through the kidney, the glomerulus, that glucose is a small molecule and you get lots of glucose in the filtrate. So this is your filtrate here in yellow, and this is your capillary next to it. Well, we have glucose and water in the capillary. We have lots of glucose and water in the filtrate. Well, there are more solute particles here in the filtrate than there are over here in the capillary. The high number of solute particles of glucose, well, water goes from high water to low water. The higher water levels are in the capillary. The lower water levels are in the kidney tubule, and water leaves the capillary and goes into the kidney tubule like that. And now you pee. Thanks to the presence of all the excess glucose in the filtrate, we're drawing water out of the capillaries that surround the tubules. So the water is being drawn from those peritubular capillaries that surround the proximal and distal tubule. There's all that glucose in there, and so you end up, your patient pees out glucose and is peeing all the time, and so they're always thirsty and they're always peeing. The third cardinal point with diabetes mellitus, of course, is they are always hungry because they need energy. They're peeing their glucose away. So the reason that we see your patient with diabetes peeing is because the high levels of glucose in the filtrate is going to pull water out of the peritubular capillaries. So let's take a look here at the role of sodium. Sodium is very important to us. It is, it's the good guy, it's the bad guy in a lot of this. 95% of all the solutes in the extracellular fluid are sodium. Sodium's key. Most of the osmotic concentration is caused by sodium. 280 milliosmoles out of 300 is caused by sodium. So in other words, sodium is key to the osmotic concentration of the solutes in the plasma, and it is the #1 solute out there. There's more sodium than any other cation, and it's the only one. It might as well be the only one because it's the only one causing any osmotic effect here. Sodium leaks in, it gets pumped out. It leaks in, it gets pumped out. But the the amount of sodium may change, but the concentration remains the same. So now, we maintain our sodium concentration by moving water into or out of the cells. Now, we know that there's potassium inside the cell. Let me back up one here. Now so we know, stop, there we go. Okay, so outside the cells, we have lots of sodium. Inside the cells, we have potassium. We have water in both places. If we increase the sodium concentration outside, water will leave the cell. If we increase the sodium concentration outside, water will leave the cell. If we have if potassium leaves the cell, water will leave. So watch this. Oh, come on. Okay. So if we lose potassium, we lose water. Water goes to the outside. If we lose sodium outside, we will lose water. So water movement is driven by the presence of sodium and potassium, mostly sodium. So while potassium has a role to play here, it's mostly sodium. #1 answer, which electrolytes most important? It's always sodium. Sodium is going to is going to maintain our osmotic concentration of 300 milliosmoles. It affects the amount of sodium present will affect the plasma. Water will always follow sodium. Water will always follow sodium. So if your patient eats a lot of salty food, they're going to retain water. They're going to retain water in their gut because they've eaten that sodium that moves into the plasma is going to have water following it. So now, how do we control our sodium? Well, aldosterone plays a big role here. We use aldosterone to recover a lot of our sodium because we have sodium. What's the filtrate? The filtrate is plasma. Plasma is salt water. We recover 99% of all the water that goes through the nephron. We pull water and sodium out at the proximal loop, proximal convoluted tubule. pull water out of the descending loop of Henle and sodium out of the ascending loop, and then we pull water out again on the collecting duct if we have antidiuretic hormone and sodium goes with it. So 90% of all the sodium that goes into the filtrate is recovered before we ever get to the collecting duct. 65% of sodium comes out in the proximal tubule, 25% in the loop of Henle, and then the remaining 10% we will recover if aldosterone is present. Because aldosterone acts on the distal tubule. Aldosterone acts on the distal tubule, so that last 10% can get recovered. And water will always follow sodium. Water will always follow sodium. And it comes back down to renin-angiotensin again. The kidneys are going to detect that pressure is low at the macula densa, or it's going to detect that sodium levels are too low because our filtration rate's too low, because our pressure's too low. And of course, renin-angiotensin will trigger the conversion of angiotensinogen to angiotensin 1, which converts to angiotensin 2, which triggers the release of aldosterone, which starts sucking up sodiums. And that brings in, sucking up sodium brings in water. And it also can kick out potassiums. The only thing wrong with aldosterone is it's slow. It's not instantaneous. Antidiuretic hormone works pretty quickly on the collecting duct. Aldosterone is slow. Problems with sodium that occur. Hyponatremia. I already mentioned that earlier about the marathoner that floods his or her body with lots of water at the end of the marathon, diluting their plasma, diluting their interstitial fluid, and end up diluting their intracellular fluid. Hyponatremia, loss of fluid, loss of sodium, vomiting and diarrhea. If you lose a lot of, if your sodium levels drop, you're experiencing hyponatremia. Well, where's that sodium coming from? Coming from the plasma. And when you dilute the plasma, you cause the cells to swell up. So profuse sweating, vomiting, diarrhea, any of these are going to cause a loss of sodium, or you can hyponatremia. Remember, hyponatremia can be losing sodium through vomiting and diarrhea, through blood loss, or you simply dilute the plasma. Now, hypernatremia, sodium levels are very high. Water loss. A person who ingests a lot of alcohol pees a lot of water loss. They can become hypernatremic. Your patient that has diabetes insipidus, if they're constantly losing water and not replacing it, the more water they lose, the more sodium they're going to have left behind. They're going to become hypernatremic. Hypernatremia, if some is good, more is definitely not better. So water loss can drive your patient into a hypernatremic state. Too much sodium because there's not enough water left behind. The causes of hypernatremia, which is much more dangerous than hyponatremia. Too much sodium caused by water loss or sodium ion overload. Taking in too much sodium. These sports drinks that contain electrolytes don't have a whole lot of extra benefit there other than the fact that they're a fluid. Because you're not losing those electrolytes. you don't lose electrolytes that rapidly. You sweat profusely during when you're playing a sport, or maybe you don't, I don't know. But you still have water loss, but you're not going to lose your electrolytes. And to overload with these sports drinks like Powerade and Gatorade, you know, by having a higher salt concentration in there, that may not necessarily be a really good thing. Now, in some cases it is, and you're dealing with a patient, particularly children who have experienced vomiting and diarrhea, water levels, fluid levels are low, and sodium levels are low. Yes, you can replace that with your with these sports drinks in here. But just to start chugging Gatorade after during a basketball game or a football game or something like that, the benefits are not as obvious. I'll just say it like that. So, okay. Hyponatremia, taking in too much water, retaining too much water. Okay, if you're hyponatremic, you're not going to be thirsty because your salt levels are low. How do you fix this? Well, you are going to the high level of water interferes. This is hyponatremia is usually a fairly easy fix here because you just pee away the extra water. Yes, you'll dilute yourself if you drink 6 bottles of water, and now we're moving into an excessive stage where it can be dangerous. But normally, a person that is overhydrated is just going to pee the water away in here. That's how you treat your patient. Okay, what about potassium? We talked sodium, number 1 ion. We've talked about sodium all along here since AP1, about the sodium and potassium pump and the sodium levels, the potassium levels, create resting potentials. Potassium is the number 1 ion inside the cells. We know what it does for us as far as depolarizing and repolarization for both muscle cells and neurons. It allows us to maintain our resting potential, minus 70 in neurons and minus 90 millivolts in muscle cells. Problems with potassium. Hypokalemia. Remember, if we see hypo, it means lower, hyper means above. Hypokalemia, low potassium levels. You get that with vomiting, you get that with diarrhea. A lot of water loss here, lose some potassium. Hyperkalemia, excessive levels of potassium. This can be fatal. High levels of potassium will excite our muscle cells. The high levels of potassium can drive us into a hyperpolarized state. It can stop the heart. If we in excessive, in very high levels of potassium, if we are in a hyperkalemic state, likely that your patient's going to be confused. They're going to have muscle twitches, maybe muscle paralysis. This is a very dangerous situation. We don't like to see our patients in a hyperkalemic state because it can kill them. So, yeah. So we pay very close attention to their potassium levels. We don't administer potassium, without any kind of thought here at all, because potassium levels, we don't want to get hyperkalemic. It's much more significant, a greater concern than being hypokalemic. Oops, I think I went. Here we go. There's potassium. Now, let's see this. Okay. Now, what about blood pressure? What does blood pressure have to do? I think I got my potassium in the wrong spot here, but that's okay. I'll just keep talking. What does blood pressure have to do with sodium and potassium levels? Well, we have baroreceptors found inside the aortic arch. We have baroreceptors at the carotid sinus that are busy telling the medulla oblongata what's going on. And we get a sympathetic response if our pressure goes up. We dilate the arterioles. If our pressure goes down, we constrict the arterioles. If our, depending on what the pressure is, we can increase the filtration rate in the kidneys, or we can lower the filtration rate. If our blood pressure is up, we can release sodium and release water if necessary. So our blood pressure receptors, can tell us what we have to do. Because if our pressure is high, we probably want to probably excrete sodium with the kidneys. If our pressure is low, we want to retain sodium, and we will retain sodium thanks to the role of aldosterone. So, yeah. We know sodium still has a role to play here. ANP, atrial natriuretic peptide, otherwise we call it ANP. ANP, it counteracts the effect of aldosterone. Aldosterone raises blood pressure by retaining sodium and retaining water. ANP detects this rise in blood pressure by stretching of the atria. The atria start stretching in the heart, then the heart will release ANP, which will prevent vasoconstriction. We know that angiotensin II is a very powerful vasoconstrictor. We know that we can release norepinephrine as a vasoconstrictor. We also know that aldosterone raises blood volume by retaining sodium and water. And if we inhibit these actions, then our blood pressure doesn't go up. The driver that triggered this is the stretch of the atria. The driver, here, so when the atria stretch, it's because our water level's up, and our water levels are up, and that means the plasma levels are up. So there's more plasma coming into the atria. They stretch and say, oh, we must have higher pressure because we're being stretched more. They release ANP, block the role of aldosterone, block the retention of sodium, block the retention of water, inhibit the effect of angiotensin II to vasoconstrict. Okay, so that first potassium was out of order. So let's, thank goodness, let me say a few things here about hyperkalemia and hypokalemia. So, okay, potassium. Back to potassium. I apologize for having that one potassium slide out of order. I'll fix that the next go around. Anyway, potassium plays a big role with membrane potential. We know that sodium and potassium are the two key players here with the resting potential, muscles and neurons. If we have too much potassium, if too much potassium, what do we use potassium for? We use potassium to repolarize. If excess potassium shows up in the extracellular fluid, it will cause depolarization because we'll see a change in the charge anyway. So we'll have depolarization, and then we won't be able to respond again. If we have less potassium outside the cell and more potassium inside, see the amount of potassium is key here. If we have lots of potassium inside the cell membrane becomes hyperpolarized. It gets us harder to get to a threshold level, whether it's a muscle cell or a nerve cell. If we have lots of potassium outside the cell, then it's easy to get to threshold. And we're more likely to have a depolarization event, but then we can't get back to another one. We've depolarized. But if all the potassium is outside, how are we going to repolarize? On the other hand, if we have all the potassium inside, we're hyperpolarized. We're further and further away from the threshold level. And if we have too much potassium inside the cell or too much potassium outside the cell, the electrical signals running across the membrane are short-circuited. It'll stop the heart. It'll stop the heart very quickly, and we'll have sudden death. Okay, let me stop here, and we will wrap this up on Monday, and then see how much we have left to cover for the semester. And I will probably end up having to record another lecture to pick up on respiratory, or well, we covered respiratory pretty well in lab, so we'll talk about it on Monday. Anyway, so because this is very important material here too. So anyway, I'm going to stop. If you have any questions on anything, shoot me an email. Reminder that we do not have class on Wednesday. So this is the last class. This is the only class for this week. And I will see you next. And there's no lab today. So I'll see you all next Monday. I hope you have a great Thanksgiving. And I'll see you when we get back.